Hello everyone. Today I will be discussing vitamin B7, also known as biotin. In this presentation, we will review its biochemical importance, metabolic functions, dietary sources, clinical deficiency states, associated genetic disorders, and diagnostic assessment, treatment strategies, and important safety considerations. My goal is to present biotin not just as a vitamin, but as a clinically relevant micronutrient with significant implications in metabolism, neurology, dermatology, and inherited metabolic disease. So let's begin. Biotin, also known as vitamin B7 and sometimes vitamin H, is one of the B complex vitamins, a group of essential dietary micronutrients required for normal cellular function. It is present in every living cell and serves as a cofactor for enzymes involved in numerous metabolic processes in both humans and other organisms. Its main roles are linked to the metabolism of fats, carbohydrates, and amino acids. The word biotin comes from the German term biotin, which itself is derived from the ancient Greek word bios or biotos, meaning life, combined with suffix in. When isolated, biotin appears as a white needle-like crystalline solid. So, from the very beginning, biotin should be understood as a vitamin essential for life at the cellular and biochemical level. Structurally, biotin is a bicyclic compound. It contains a urido ring fused with a tetrahydrothiophene ring along with a valeric acid side chain. Functionally, biotin acts as a prosthetic group. This means it becomes covalently attached to specific enzymes, particularly the carboxylases, and is required for their activity. In simple terms, biotin is not just loosely associated with these enzymes, it is physically linked to them in order to enable them to work. Without biotin attached, these enzymes remain inactive. This point is clinically important because biotin deficiency essentially results in impaired function of multiple enzyme systems, which explain the broad metabolic and neurological consequences we see in deficiency states. At this point, the presentation moves into the historical context of biotin discovery. In 1916, W.G. Batman observed that a diet high in raw egg whites causes toxic symptoms in dogs, cats, rabbits, and humans. By 1927, scientists such as Margaret Boas and Helen Parsons had performed experiments demonstrating the symptoms associated with egg white injury. They had found that rats fed large amounts of egg whites as their only protein source exhibited neurological dysfunction, hair loss, dermatitis, and eventually death. In 1936, Fritz Kogel and Benno Tonis documented isolating a yeast growth factor in journal article titled Representation of Crystallized Biotin from Egg Yolk. Other research groups working independently had isolated the same compound under different names. Hungarian scientist Paul Georgi began investigating the factor responsible for egg white injury in 1933 and in 1939 was successful in identifying that he called vitamin H. Further chemical characterization of vitamin H revealed that it was water soluble and present in high amounts in the liver. After experiments performed with yeast and Rhizobium trifoli, West and Wilson isolated a compound they call coenzyme R. By 1940, it was recognized that all three compounds were identical and were collectively given the name biotin. Georgi continued his work on biotin and in 1941 published a paper demonstrating that egg white injury was caused by the binding of biotin by avidin. Using E. coli, a biosynthesis pathway was proposed by Rolfe and Eisenberg in 1968. This historical development laid the foundation for later discoveries in metabolic disease, nutritional deficiency, and inherited enzyme defects. Now let's talk about biochemical functions and metabolic roles. Biotin's most important biochemical function in carboxylation reactions. It serves as a carrier of carbon dioxide for five essential carboxylase enzymes. Pyruvate carboxylase converts pyruvate to oxaloacetate, replacing the TSA cycle and enabling gluconeogenesis, making glucose from non-carbohydrate sources, crucial for brain glucose supply. Acetyl-CoA carboxylase ACC1 and ACC2 catalyzes the first committed step in fatty acid synthesis, converting acetyl-CoA to malonyl-CoA, also regulates fatty acid oxidation. Propionyl-CoA carboxylase converts propionyl-CoA to methylmalonyl-CoA, involved in the metabolism of odd chain fatty acids, certain amino acids such as valine, isoleucine, methionine, and threonine. and cholesterol. 3-methyl-crotonyl-CoA carboxylase involved in the catabolism of the amino acid leucine. This CO2 carrying function is central to its metabolic importance. Through these carboxylase dependent reactions, biotin contributes to critical pathways involving energy production, intermediary metabolism, and the handling of fats, carbohydrates, and amino acids. Biotin also undergoes a process known as the biotin cycle, which allows the vitamin to be degraded and then recycled efficiently. Active enzymes or holocarboxylases undergo proteolytic degradation, producing biotinyl peptides. These are then acted upon by biotinidase, which releases free biotin. This free biotin can then be reused by holocarboxylase synthetase to form new holocarboxylases. This recycling system is extremely important because it helps preserve functional biotin availability within the body. In addition to its classic metabolic role, biotin also has epigenetic function. It can be covalently attached to histone proteins, a process referred to as histone biotinylation. One example noted here is H4K12 bio, which is associated with gene repression. Biotinylation also influences chromatin structure, affecting chromatin compaction and DNA accessibility. So, biotin is not only involved in metabolism but may also influence how genes are regulated and expressed. Now, let's look at the pharmacokinetic aspects of biotin, how it absorbed, metabolized, distributed, and excreted. Biotin in food exists in two forms: protein bound biotin, most dietary biotin, and free biotin in plant foods and supplements. Digestive enzymes reduce the proteins to biotin bound peptides. The intestinal enzymes biotinidase found in pancreatic secretions and in the brush border membranes of all three parts of the small intestine freeze biotin, which is then absorbed from the small intestine. When consumed as a biotin dietary supplement, absorption is non-saturable, meaning that even very high amounts are absorbed effectively. Transport across the jejunum is faster than across the ileum. The large intestine microbiota synthesizes amounts of biotin estimated to be similar to the amount taken in the diet, and a significant portion of this biotin exists in the free protein unbound form and thus is available for absorption. How much is absorbed in human is unknown, although a review did report that human colon epithelial cells in vitro demonstrated an ability to uptake a biotin. Once absorbed, sodium-dependent multivitamin transporter SMVT mediates biotin uptake into the liver. SMVT also binds pantothenic acid, so high intakes of either of these vitamins can interfere with these transports of the other. Biotin catabolism occurs via two pathways. In one, the valeric acid side chain is cleaved, resulting in bisnorpbiotin. In other path, the sulfur is oxidized, resulting in biotin sulfoxide. Urine content is proportionally about half biotin plus bisnorbiotin, biotin sulfoxide, and small amounts of other metabolites. Now let us review the recommended intake values for biotin across age groups. For infants, the adequate intake is 5 micrograms per day from birth to 6 months and 6 micrograms per day from 7 to 12 months. For children, the intake rises with age: 8 micrograms for 1 to 3 years, 12 micrograms for 4 to 8 years, and 20 micrograms for 9 to 13 years. For adolescents aged 14 to 18 years, the recommendation is 25 micrograms daily. For adults aged 19 years and above, the intake is 30 micrograms per day. During pregnancy, the recommended intake remains 30 micrograms daily, while during lactation, the requirement increases slightly to 35 micrograms per day. These amounts are relatively small, which helps explain why true deficiency is uncommon in individuals consuming a varied diet. Biotin is found in variety of animal and plant foods. Among the richest listed sources is cooked beef liver providing 30.8 micrograms per 85 grams, a large cooked egg provides 10 micrograms, and canned pink salmon provides 5 micrograms per 85 grams. Other sources include cooked pork chop and cooked hamburger patty, each at 3.8 micrograms, roasted sunflower seeds at 2.6 micrograms per quarter cup, and cooked sweet potato at 2.5 micrograms per half cup. Lower but still useful amounts are found in roasted almonds, canned tuna, boiled spinach, fresh broccoli, mild cheddar cheese, 2% milk, and plain yogurt. This variety is clinically relevant because it reinforces the point that biotin deficiency is rare in healthy individuals with reasonably diverse diet. Now let's talk about clinical manifestations of biotin deficiency. True biotin deficiency is rare in healthy individuals who eat varied diet. However, it does occur under specific conditions. One classic cause is prolonged consumption of raw egg whites due to avidin binding, which interfere with biotin availability. Another major cause is biotinidase deficiency, an inherited enzyme disorder that impairs biotin recycling. Similarly, holocarboxylase synthetase deficiency is a rare inherited disorder that also leads to functional biotin deficiency. Deficiency may also occur in patients receiving prolonged parenteral nutrition without biotin supplementation, in those taking long-term anticonvulsants such as valproic acid or carbamazepine, in individuals with chronic alcohol use, and in cases of severe malnutrition. So, when evaluating deficiency, we must think not only for poor intake, but also impaired recycling, impaired utilization, drug effects, and clinical settings of nutritional vulnerability. The dermatological manifestation of biotin deficiency are often striking and can provide important diagnostic clues. The classic skin presentation is a seborrheic-like or psoriasis form dermatitis. The rash is typically scaly, erythematous, non-pruritic, and distributed in characteristic pattern involving the periocular, perinasal, perioral, or perineal and perianal regions. This pattern is important because it resembles the rash seen in zinc deficiency, specifically acrodermatitis enteropathica and also in pellagra, which can create diagnostic confusion. Another major feature is alopecia, which can range from simple hair thinning to complete loss of scalp and body hair. Eyebrows and eyelashes are often affected as well. Interestingly, when hair regrows, it may initially be lighter in color. Nail findings may include brittleness, longitudinal ridging, and koilonychia or spoon-shaped nails. For clinicians, these dermatologic signs should always prompt consideration of nutritional deficiency and metabolic disease in the right context. The neurological manifestation of biotin deficiency affects both the peripheral and central nervous systems. Peripherally, patient may develop paresthesias described as tingling or burning sensations, along with numbness and reduced deep tendon reflexes. Centrally, the consequence can be much more serious. These include seizures, especially in infantile presentation, hypotonia, particularly in neonates, ataxia, developmental regression, and sensorineural hearing loss and optic atrophy. Biotin deficiency is also associated with significant metabolic derangements. These include lactic acidosis, organic aciduria, and accumulation of urinary metabolites such as 3-hydroxyvaleric acid, 3-methylcrotonyl glycine, and methyl citric acid. In severe cases, patient may develop hyperammonemia related to propionate accumulation. Other findings include hypoglycemia due to impaired gluconeogenesis and ketosis. This combination of dermatologic, neurologic, and metabolic abnormalities is what makes biotin deficiency such an important multi-system disorder. Biotin deficiency also has immunological consequences. It impairs both humoral immunity and cell-mediated immunity. Adequate biotin is necessary for T lymphocyte and B lymphocyte proliferation, and deficiency also reduces natural killer cell cytotoxicity. Clinically, this means that deficient individuals may present with recurrent mucocutaneous candidiasis, such as oral thrush or vaginal candidiasis, or with other opportunistic infections. These may appear before or alongside the more classic dermatological signs. Another feature described here is the so-called biotin deficient facies, characterized by a distinctive facial rash and unusual fat distribution. Taken together, these findings emphasize that biotin deficiency is not merely a cosmetic or dermatologic issue, it can affect immune function and overall systemic health. We now move to inherited disorders of biotin metabolism, beginning with biotinidase deficiency. This is an autosomal recessive disorder caused by mutation in the BTD gene. The key problem is impaired recycling of biotin from biotinyl peptides. As a result, patient develop a functional biotin deficiency even if dietary intake is adequate. If untreated, the usual onset is between 3 months and 10 years of age. Clinically, the condition presents with both neurological and dermatological features. Neurological manifestations include seizures, hypotonia, ataxia, developmental delay, optic atrophy, and hearing loss. Dermatologic manifestations include alopecia and skin rash. Metabolically, patient may show organic aciduria and ketolactic acidosis. This disorder is particularly important because it is highly treatable when recognized early. Another important inherited disorder is holocarboxylase synthetase deficiency, also an autosomal recessive disease caused by mutation in the HLCS gene. Here, the defect is in the attachment of biotin to apocarboxylases, which means the enzymes cannot be activated properly. This disorder generally presents earlier than biotinidase deficiency and is often more severe. Clinical features are similar but may include pronounced metabolic acidosis, ketosis, feeding difficulties, vomiting, hypotonia, lethargy, and seizures. This slide also introduces biotin thiamine responsive basal ganglia disease or BTBGD. This is an autosomal recessive disorder caused by mutation in the SLC19A3 gene. The underlying problem is impaired transport of biotin and thiamine across the blood-brain barrier. Let us now consider how biotin status is assessed in clinical practice. The most direct measure is plasma biotin concentration, but this is relatively insensitive in early or marginal deficiency. Plasma levels may remain within normal range even when tissue stores are already compromised because the body tends to maintain plasma concentration at the expense of intracellular reserves. The reference range given here is approximately 133 to 329 picomoles per liter, though this varies by laboratory. A particularly important functional biomarker is urinary 3-hydroxyisovaleric acid or 3-HIA. This is currently considered the most sensitive functional biomarker of biotin status. It accumulates when methylcrotonyl-CoA carboxylase activity is impaired, even in subclinical deficiency, and can be measured on spot urine sample normalized to creatinine. An elevated value above 195 millimoles per mole creatinine indicates functional biotin insufficiency even before plasma levels decline. A more sensitive early marker is urinary biotin excretion, which falls early in deficiency. In deficiency states, the 24-hour urinary excretion may fall below approximately 20 nanomoles per day. In severe deficiency states and in propionyl CoA carboxylase deficiency, propionyl carnitine or C3 and methyl citric acid may also be elevated in dried blood spots, which is relevant in newborn screening. Beyond the general biomarkers, more specific diagnostic tools are available for inherited disorders. Biotinidase activity measured in serum or dried blood spot is the primary test for biotinidase deficiency and is included in newborn screening panels worldwide. Activity less than 10% of the mean normal value indicates profound deficiency, while values between 10 and 30% indicates partial deficiency. Carriers typically have around 50% activity. Lymphocyte propionyl CoA carboxylase activity can also be measured directly to assess carboxylase function, although this is primarily a specialist or research tool. When holocarboxylase synthetase deficiency is suspected, activity can be assayed in fibroblast or lymphocytes. Finally, a genetic testing provides definitive molecular diagnosis. This includes BTD gene sequencing for biotinidase deficiency, HLCS gene sequencing for holocarboxylase synthetase deficiency, and SLC19A3 gene sequencing for BTBGD. So, diagnosis may combine biochemical markers, enzyme assays, and molecular testing depending on the clinical context. Now, let's talk about how to treat biotin deficiency. In acquired biotin deficiency, treatment is generally straightforward and effective. For oral supplementation in adults, the dose listed is 5 to 10 milligrams per day until symptoms resolve. Maintenance can then be achieved through normal dietary intake of approximately 30 to 100 micrograms per day. In drug-induced deficiency, especially with anticonvulsants such as phenobarbital, phenytoin, and carbamazepine, these medication may increase biotin catabolism. In such cases, supplementation of 1 to 5 milligrams per day may be beneficial. In multiple sclerosis, where high-dose biotin, specifically 300 milligrams per day as MD1003 was investigated because of proposed role in myelin repair and energy metabolism. However, phase 3 trials show no significant benefit for disability or walking speed, so it is not recommended for routine use. For hair, skin and nails, the evidence remains limited. The slide notes that brittle nails may improve with 2.5 milligrams per day for several months, and children with uncombable hair syndrome show improvement with 3 to 5 milligrams per day. This section is clinically useful because it distinguishes between established therapeutic uses and areas where evidence remains weak or investigational. Treatment becomes more specific in inherited biotin related disorders. In profound biotinidase deficiency, defined as less than 10% enzyme activity, lifelong treatment with 5 to 20 milligrams of biotin daily is recommended. In partial deficiency, where enzyme activity is 10 to 30%, lifelong treatment with 2.5 to 10 milligrams daily is used. The prognosis is described as excellent if treatment is started before symptoms develop. In holocarboxylase synthesis deficiency, higher doses are needed, typically 10 to 80 milligrams of biotin per day, again as lifelong therapy. Because this condition present earlier and can be more severe, prompt treatment is essential. For biotin thiamine responsive basal ganglia disease, treatment consists of high dose biotin at 5 to 10 milligrams per kilogram per day combined with thiamine and must also be continued lifelong. Now let us consider the safety profile of biotin. A tolerable upper intake level has not been established. This reflects the fact that there is no clear evidence of toxicity at high intakes in humans. But biotin is well tolerated at doses up to 200 milligrams per day. Potential side effects are described as rare but may include upset stomach, insomnia, excessive thirst, and increased urination. A very rare but serious adverse event noted here is eosinophil pleuropericardial effusion, which is potentially life threatening. So, overall, biotin is generally considered safe, but like all supplements, especially at high doses, it still deserves thoughtful clinical oversight. An important and very practical aspect of biotin is its interaction with foods, drugs, and laboratory testing. Raw egg whites can block absorption due to avidin. Alcohol can impair intestinal absorption and increase renal excretion. Anticonvulsants such as valproate, carbamazepine, phenobarbital, and phenytoin may increase biotin catabolism and reduce absorption. Isotretinoin or Accutane may impair biotin activity. The slide also notes that antibiotics can kill gut bacteria that synthesize biotin. Although the effect on overall status is probably minor, it may still be worth considering during prolonged use. Perhaps most clinically significant is the effect of high-dose biotin supplements on laboratory tests. Biotin can interfere with biotin streptavidin immunoassay platforms, which are among the most commonly used laboratory assay methods worldwide. This is a critical practice point because supplement use can potentially distort lab interpretation and lead to diagnostic confusion. So, whenever reviewing unexplained laboratory abnormalities, asking about high dose biotin use is essential. To conclude, biotin is a small but essential micronutrient with broad physiological significance. It serves as a cofactor in key metabolic reactions, participates in biotin recycling and gene regulation, and has important clinical relevance in nutritional deficiency, inherited metabolic disease, and laboratory medicine. Thank you very much for your attention, guys. I hope this discussion has provided a clear and clinically useful overview of vitamin B7 or biotin. And if you found this educational, please like, share, and subscribe to the Docsaab's Diary for more high yield clinical content. Thank you.